Hi guys, welcome to this discussion regarding COPD, and this is primarily a small airway disease. The definition of the word small airway would be that the diameter or the caliber of the airway is less than 2 millimeter in size. Now, since this is an obstructive airway disorder and even asthma is an obstructive airway disorder, so the question arises, what's the difference? The difference is with respect to reversibility. In a patient with bronchial asthma, you will notice that when you're gonna check out the FEV1 of the patient, it will obviously be less. So you would be giving bronchodilator to the patient and ask the patient to wait outside the spirometer room. After, let me say, 15 minutes interval, if you are gonna check out the FEV1 again, because the drug will start working, the FEV1 of the patient will tend to rise towards normal. So mathematically speaking, I just want to reiterate the statement that the change of FEV1 should be approximately 12% to call it bronchial asthma. But COPD, the topic that we're studying at the moment, is a non-reversible airway disorder. Why non-reversible? Because in this condition, you don't have a bronchospasm, but the main lesions would be in the form of either blebs or bullas. The problem with these blebs and bullas would be development of air trapping. So therefore, if I'm gonna check out the FEV1 of this patient of COPD post bronchodilator administration, the FEV1 will not show any significant change, and in most of the cases, it's gonna remain the same. MCQ wise, you just need to remember this cutoff value that I'm speaking before you. Post bronchodilator in COPD patients, the FEV1 FVC ratio will still remain less than 0.7. Apart from this, as I will progress in the disease, I'll talk about the treatment part, but I'm just highlighting one statement because traditionally whenever you read the word triple therapy, you always are gonna be associating it with Helicobacter pylori, but you will notice triple therapy word being used even in COPD. So I would like to mention the drugs at the outset here only. One of them would be LAMA, molecules like tiotropium. In fact, LAMA administration has been shown to reduce the exacerbations of this condition. Apart from this, we can be using inhaled corticosteroids and even LABAs as well. So when you are going to be using these three drugs together, you will notice that you would be having a substantial reduction in the exacerbations of these patients. And in fact, one of the indicators for starting inhaled corticosteroids in these patients is eosinophil count. Yes. Traditionally, when you read about eosinophil count, the impression is that we are reading about bronchial asthma. I mean, every time we read asthma, right, it's going to be related to allergy. So our thought process is eosinophil count is related to asthma. I agree to that. But in the current update, the gold classification 2021 update, he has mentioned biomarker of disease activity. Like we are always looking for biomarkers of various diseases, like in the kidney section for acute kidney injury, I've talked about NGAL, neutrophil gelatinase associated lipocalcin. In MI, I've talked about troponin I. Similarly, in the same spirit, I'm talking about biomarker of COPD activity would be a eosinophil count. And if the eosinophil count is given to be in the question, in the stem of the question, to be more than 300, then this is definitely one of the indications for starting oral corticosteroids in the patient. In fact, I would like to highlight two statements for eosinophil count for COPD per se. As I mentioned, a cutoff here. I mean, if the value is given to be more than 300, that means that inhaled corticosteroid should be started. But simultaneously, also mentions in the update that if the eosinophil count of the patient is lesser, it means that there would be increased incidence of pneumonia in these patients. You very well know that patients of COPD can not only be having a possibility of developing COVID-19 pneumonia, but apart from this, even I would say pneumococcal pneumonia would be common in these patients. Anyway, I'll talk about the vaccination component. So we need to be sure that geriatric age group patients with COPD, at least because in India, obviously cost is obviously a consideration, at least geriatric age patients, though ideally every patient with COPD, traditionally in the exam you will say every patient with COPD should be protected against pneumococcus, should be protected against Haemophilus influenzae, and also protected against COVID-19. So the vaccination part is definitely going to play a very, very important role. And I would also like to use this opportunity to mention why there is a higher incidence of COPD in Indian women from rural India who are not smokers. Well, I can say biomass combustion. You very well know that for cooking, though government has tried couple of schemes and you read about them in PSM also for use of LPG gas for cooking purposes, but you still know that in rural India, they might be using wood, or they might be using charcoal, and they might be using even the cow dung cakes. So biomass combustion is a big problem in India from the perspective of the fact that this will contribute to significant indoor pollution, and this indoor pollution will then contribute to higher incidence of COPD, especially in women from rural India. The government, as I said, has taken initiatives to reduce the burden per se. So these are some baseline informations that I have mentioned for this topic of COPD. And what I say next is valid for those of you who have used the previous edition of the app. I mean, the older video also you have listened to me 2020 version, because what I'm saying, I'll write it down also, that is 2021 version. I want you to remember that in older version, I said steroids are to be given with respect to category C of symptom severity. But in the 2021 update, he has mentioned that steroids, inhaled corticosteroids, should be started in category D of symptom severity. Now, if you are new to the app, if you are a new subscriber and you're listening to this for the first time, don't worry. I'll definitely be writing down the data, and I will be talking about the gold classification, so things will be pretty smooth for you. But since a lot of people might have listened to my previous version of COPD as well, 2020 version, so I thought at the outset I mentioned a very important change with respect to when are you gonna launch inhaled corticosteroids for management of the patient. Older data was categorization C, and nowadays it is symptom severity grade D. So I'll definitely describe it as we progress in the discussion. And now we will focus on two spectrums of the disease, emphysema and chronic bronchitis. Now in reality, there is a possibility that there is an overlap. In fact, in majority of cases, there is always an overlap present. So though I will be describing the data to you in, let me say, shades of black and white, but in reality, it is a combination of the two. It would be a shade of gray, because clinically we write like this: emphysema predominant COPD, chronic bronchitis predominant COPD. But when I have to explain the disease for the first time from the pathology domain as well as from the clinical domain, I will try to present the data to you as if these diseases are grossly different, but they definitely have a distinct overlap. So let's look at the small airways here. What I've represented here before you is the acinus. We have the terminal bronchiole, the respiratory bronchiole, the alveoli, which is the basic unit of gas exchange. And when a cigarette smoker is gonna puff on a cigarette, then tar is gonna go into the lungs of this guy. The moment the tar goes into the lungs, it will contribute to irritation of the security system, that is alveolar macrophages, and these guys will be very active and they will be responding to this stimulus by producing elastase. Now the problem with elastase is that it will contribute to damage to the elastin component of the connective tissue, which is going to form the structural support of the small airways. If I take this to be the representation of the acinus per se, what we usually find is that the highest concept, I mean, tar is going to spread everywhere in the lungs. It's going to go to the smallest of the smallest airways. But we usually find that this particular area that I'm marking before you, the central part of the acinus, that's the area of the respiratory bronchiole. I'll just write RB here for respiratory bronchiole. This is the area that is worst affected. So therefore, you always read the term centriacinar emphysema with respect to a cigarette smoker. Now, do remember the fact that in the older edition of Robbins, it was mentioned that the mixed variety of emphysema is common, but currently in the newer edition is clarified what we as medicine people were saying all the time, that the commonest type of emphysema is centriacinar emphysema. So both books, both Robbins and Harrison, would be in sync with respect to the commonest variety. And I hope you recall in bronchiectasis, I've told you that the commonest variety that you find from the pathological perspective is the cylindrical variety. Now, once there's going to be centriacinar emphysema after, let me say, 20 years of cigarette smoking, let's look at how the small airways of this person will look like. I have drawn the terminal bronchioles again, but now I am showing structural damage to the wall of the respiratory bronchiole, which is going to create formation of what is called as blebs. These blebs then unite with each other to form bigger ones, which are called as bullas. And apart from this, I have also tried to distort the appearance of the alveoli by saying that there will also be a alveolar scarring present. So you can see that the impact of cigarette smoke and even indoor pollution is such that even the alveoli get involved, the basic units of gas exchange are hampered, and because of this the availability of oxygen around and in this area per se will be hampered. In fact, let me just represent this before you. Look at the very symmetrical airway distribution and the gas distribution with respect to acinus of a normal person. But in this person, what will happen is, just keep your eyes on the screen at the moment, do not note down, lots of air will get wasted in this area. The air will be stuck in the blebs of this patient, as a result of which the total amount of air that is reaching will definitely be lesser. So what I'm just trying to highlight here is that because of the wastage of the gas in this case, the total availability or the total delivery to the alveoli is lesser. Because of the lesser delivery, it will anyway explain why do we read that there is going to be hypoxia, which will contribute to hyperventilation. So if you've seen a patient of COPD, even if he's not having exacerbation, if they're having exacerbation, they will anyway be bad. But even if he's not having an exacerbation, you will notice that the person will be having a faster breathing as compared to you and me while sitting on a chair. There's an insidious onset or development in these patients. So I also want to highlight one clinical fact here. Like if you are gonna talk to this cigarette smoker, he will tell you, doctor, initially like I could, go for shopping and I could push a shopping cart, or I could even walk on a treadmill. You see, if you look at the position of my arms, the way at the moment is, I can say that this person would be, because of the splinting of the arms per se, because you're pushing let me say a shopping cart, or if you're walking on a treadmill and you're using supports, because your arms are splinted, you can use your accessory muscles of respiration, and with the use of accessory muscles of respiration, initially they may be able to maintain their oxygen saturation. So he might say, sir, I was leading a very healthy lifestyle. I could go for shopping, I could walk on a treadmill, never a problem. But as the disease severity will worsen, that is when the person will not be able to do even these chores per se. And why I mentioned the position of the arms is, in exacerbation, you would have noticed that these patients tend to sit with their arms in a forward propped up, right? And you always read about the word tripod position. So the arms are splinted to utilize the accessory muscles of respiration to improve their oxygen saturation. And I also said that even when they are sitting on a chair, because they'll be breathing faster as compared to you and me, so there will be a carbon dioxide washout, as a result of which the values of partial pressure of carbon dioxide in these patients can be normal or even lesser than normal. Now traditionally, because they love to ask regarding type 1, type 2 respiratory failure, so you very well know that if a person is having less oxygen and more carbon dioxide in the body, if the PCO2 is more than 45, we call it type 2 respiratory failure, but here PCO2 is less. So emphysema per se, if written in a multiple choice question, I want to highlight this fact. If emphysema word is given and he says what kind of respiratory failure is anticipated in this patient, your answer would be type 1 respiratory failure. And every example of type 1 respiratory failure will be having a carbon dioxide washout, so production of protons will also be lesser. If protons production is lesser, then it will contribute to respiratory alkalosis. And I've already told you that in these patients, if you're gonna check out the FEV1 before and after giving salbutamol, then there will be no changes, unlike in bronchial asthma, where I mentioned a 12% increment. Let us just look at this air trapping component once again. I'll use a marker which is gonna dissipate in a while, but just follow my marker at the moment. I've asked this guy, sir, breathe out as hard as you can. Now this is the way the air will go out, but then a lot of this air will again get trapped in these blebs. Lot of this air will be trapped in the blebs. If you just focus on the English word that I said and I'm writing before you, air trapping, just think logically and tell me what is going to happen to the FEV1 of this patient. The air is again going to be trapped in the bleb. So FEV1 of this patient will anyway be lesser. So I'm just going to put arrows here to say that FEV1 of these patients will always be less than normal, and it's not going to change with respect to the administration of bronchodilator. But because of this air trapping, some spirometric parameters will definitely show an increment, like a residual volume of this patient will be increased. As a result of it, total lung capacity will also be increased. So whenever you read a question with respect to emphysema per se, he's not only going to talk about FEV1 FVC ratio less than 0.7, but these two spirometric parameters can also be introduced. And traditionally in the books, we always read about emphysema patients as pink puffers and chronic bronchitis patients as blue bloaters. So I'm going to tell you why we call him a blue bloater as we progress. But at the moment, I want to say that in emphysema, we do not have presence of central cyanosis, so you're calling him going pink and puffer because he obviously keeps on puffing on a cigarette. And one more interesting fact on this slide that I want to bring to your notice is that I have deliberately shown some of these blood vessels to be severely constricted, because whenever there's going to be hypoxia, whenever the delivery of oxygen will be lesser, even the blood vessels will constrict. So you're not only having a problem with delivery. The problem with delivery is because of two reasons: wastage of gas and alveolar scarring. But along with this, I can say even ventilation perfusion will also be affected in these patients. And if they have an exacerbation, like if they have a viral pneumonia, if they are having COVID-19, then this ventilation perfusion imbalance can turn lethal, because COVID-19 itself contributes to development of a interalveolar edema. It causes a ventilation perfusion imbalance, and if there's a pre-existing one, then I can just say that God help this person, because the deterioration will be faster. And that's why I was initially emphasizing that the vaccination for COPD patients should be as ideal as possible, so that the chances of these patients developing any lung infection and then deteriorating can definitely be reduced. Next, I'll be explaining to you here radiological findings that you would be able to see in a patient with COPD. One of the highlights would be because of air trapping, the dome of the diaphragm will be pushed downwards. So flattening of the diaphragm is a technical term that will always be written, or you can just write the word hyperinflation in a chest X-ray. The lungs will look more black than normal. I repeat the findings. I said the lungs are gonna look more black than normal because there is air trapping, but vascular markings will be less pronounced but will not be absent. Why am I saying that is because if you have listened to my discussion on pneumothorax, even in pneumothorax, the X-ray will look more black than normal, but at the same time, vascular markings will be at least not visible in a pneumothorax case. In this particular case, I'll just mark it. You can still see some whiteness, some areas of whiteness with respect to the vasculature. So this is an important point, because every time you're gonna get a jet black X-ray, you might be tempted to think in terms of even a pneumothorax in a person, but always have a good look at the pulmonary vasculature. If it is lesser, then it's definitely not a pneumothorax. I mean, if you can see the shadow blood vessels, it's unlikely to be pneumothorax. Other findings of pneumothorax can definitely be like a deep sulcus sign that I've highlighted. They will definitely be a mediastinal shift. Whereas in this case, what you are also noticing is that the heart looks relatively smaller. I mean, it's not that the heart is smaller or the cardiothoracic ratio is lesser. All I'm saying is because the lung is expanded, the expanded lung is going to cover the heart, due to which the findings that will be written will be tubular heart. So let's just repeat the findings once again. With respect to a person who's having emphysema, predominant COPD, there is going to be evidence of air trapping. So if he writes hyperinflation, it's anyway a piece of cake for you. Otherwise, you need to pick up the flattening of the diaphragm, lungs looking slightly more black than normal, pulmonary vasculature being on the lower side, and a tubular heart, which I said is going to be like a cardiothoracic ratio is relatively reduced. If he just says what is the preferred imaging modality for these patients, then I would prefer a high resolution CT chest, because it will anyway help me identify chronic bronchitis component, because there's a possibility that in a patient in one lobe it's predominantly emphysematous changes, in another lobe there might be chronic bronchitis changes as well. Over and above this, I also want to check out the bullas which are present in the lungs of these patients, because these bullas can rupture anytime. Now, the importance of knowing this information is that every time you read a question that says that a COPD patient has developed deterioration of his respiratory status, in a sense that there is a severe respiratory distress, it just happened while he is watching television. This COPD guy, like, I'm not saying that he has developed some lung infection and then subsequently after 2-3 days there's a deterioration. This COPD patient is sitting at home, is fully vaccinated for COVID-19, uses mask, everything is perfect. He doesn't step out, also gets groceries from Amazon. I mean, everything with respect to infection control, this guy has taken care of. But while sitting at his home watching television, watching news, there was a sudden onset respiratory distress in a known cigarette smoker. He would not use the word COPD, he'll just say a cigarette smoker. There's a sudden onset respiratory distress, and the level of distress is so bad that he can't even speak. He's just trying to signal with his hands to his family member that take me to a doctor, I just can't breathe. And maybe the lungs are so affected at this moment that the lips are turning blue. Then this means the fact that this guy has had a rupture of the bulla, And the complication that I've also discussed in the pneumothorax topic would be a development of a spontaneous pneumothorax. So this is anyway an important aspect from the perspective that if the question says overall, what is the most common complication? If the MCQ simply says, what is the most common complication of emphysema? Then answer is obviously not pneumothorax. The overall commonest complication that you encounter in a person of emphysema would be, because long-standing hypoxia is very much there. So this person will end up with development of cor pulmonale. Cor pulmonale will contribute to right ventricular failure in this patient. That will contribute to subsequent even pedal edema and a hepatomegaly. Now the chances of development of cor pulmonale has dramatically reduced nowadays because of the ease of availability of low flow oxygen. We will be using a nasal cannula, a very soft one that ensures that this guy receives low flow oxygen at 1 to 2 liters per minute for maximum number of hours per day. The advantage of giving low flow oxygen is that low flow oxygen is the only way by which you can reduce mortality. Remember, I was talking about triple therapy. I talked about usage of steroids, but none of the drug therapy has been shown to reduce mortality in these patients. In the exam, if he says, what is the one single intervention that reduces mortality in a COPD patient, emphysema patient, your answer is going to be low flow oxygen. And because of the ease of availability nowadays, this complication has definitely become lesser. Though if obviously this is not available, then the person will deteriorate. On the other hand, I also told you that if he just says everything has developed suddenly because cor pulmonale, right ventricular compliance being affected, this is going to take time. But if he's going to talk about a sudden deterioration in a person, then you must think in terms of possibility of spontaneous pneumothorax in a patient of emphysema. I shall now be describing the other end of the spectrum, that's going to be chronic bronchitis. So let's have a look at the ciliated columnar epithelium which is present in the airways. This is the cilia, and all of these cilia beat in the same direction. The objective of this mucociliary escalator is to keep the lung secretions in a constant state of motion, or you can just take this mucociliary escalator as the cleaning mechanism of the lung. Now, if a guy is a heavy smoker, then this tar will contribute to ciliary damage. And because of this, there would be stasis of secretion in the lungs of these patients. Because of the stasis, there will definitely be a possibility of a low-grade infection, and therefore you will be having a presence of purulent bronchoria. Whenever you read about purulent bronchoria, you always have to think in terms of one is bronchiectasis, second is going to be chronic bronchitis. But if he begins by saying a cigarette smoker and then mentions regarding this bronchoria, and even he is having exacerbation, especially in winter season, or like in India, you will notice that in November and December starting, there is a lot of outdoor pollution and the air quality index will deteriorate. So these patients can be having worsening, and then they will be having production of extensive amount of sputum primarily. So the three common symptoms that would be written in a MCQ of chronic bronchitis would be a smoker who would be having cough. Along with this, there would be a lot of sputum production, expectoration, and the third would be exertional dyspnea. Like he says, I could earlier go for shopping independently, or I even was an active person. I could walk on a treadmill, but now my exercise capacity has significantly reduced. When I'm saying the ciliary damage component, I just want to highlight that this is grossly different from Kartenegger syndrome. In Kartenegger syndrome, though it has been covered earlier, but just to put it on record, we will be having immotile cilia. So there's a difference between the two from the perspective of why there is a stasis of secretions. I mean, when you read about Kartenegger syndrome, I have described person would be having development of bronchiectasis, whereas in chronic bronchitis, it is mainly the fact that the cilia, which are the cleaning mechanism, is affected, and this again should not be confused with cystic fibrosis, in which the mucus which is produced is very thick. Cystic fibrosis is a separate discussion. I've talked about mucoviscidosis. So chronic bronchitis versus Kartenegger versus cystic fibrosis, the differences, the fundamental differences are the ones which are to be remembered. Now, what's going to happen in the small airways of this patient would be, once again, I'm sketching the terminal bronchiole, respiratory bronchiole, and then the acinus. There's a possibility that this purulent sputum, which is going to be produced here, can occlude the airways. The smaller airways, size being approximately 2 mm or lesser, are being physically occluded, and the pus could be sticking to the inside of the airways also. As a result of it, if I show air entry, One, I'm showing a bit of turbulence. I could have drawn a straight line. I've shown a bit of turbulence coming up. Why? Because the caliber of the airway is lesser, not because there is a bronchospasm, but because there are lung secretions which are present. And then you can see that obviously air cannot travel forwards at all, in contrast to the contralateral side. So there is a definitive component of hypoventilation which is present in these patients. In contrast, when I was describing emphysema to you, I was describing hyperventilation. Now I'm teaching you hypoventilation. Why am I saying hypoventilation? Is because in this particular person, even if he will breathe faster, he will still not be, listen to the words carefully, even if he will breathe faster, even if he will use the accessory muscles of respiration, he will still not be able to deliver oxygen into the airways. Why? Because there's a physical obstruction present. Because of this hypoxia component, the blood vessels that I'm showing here are also severely constricted. Compare this with the caliber of the blood vessels in the contralateral alveoli of this patient. So what I have tried to highlight here before you is the fact that the severity of hypoxia in patients of chronic bronchitis is more than that in emphysema, because there is a airway closure. In contrast, when you look at emphysema, it was rather a distension of the airways, dilatation of the airways, destruction of the airways, and formation of bullas which were contributing to air trapping. And above the hypoxia component, I mean, this hypoxia subsequently can be so severe that you could be having even cyanosis present in this guy. And because of the hypoventilation component, see, this particular alveoli cannot contribute to carbon dioxide excretion. Carbon dioxide will be excreted from this particular side, but carbon dioxide can't be excreted from this side. As a result of it, the carbon dioxide values in the body of this person will start rising, and will rise even further if they're gonna have a exacerbation. Because of the rise of the carbon dioxide values, you will also notice that these people will tend to sleep for most part of the day. The physical activity, I mean, we always tell our COPD patients to maintain a daily routine and try to do a bit of physical activity to the level that they can tolerate. But in these people, because of increase of carbon dioxide, the person will feel sleepy for most part of the day. There will be a physical activity restriction, which will explain why these patients will tend to put on some weight, and therefore you always read the word blue bloaters. So I have just tried to explain here why COPD, especially chronic bronchitis component, is referred to as a blue bloater, because the person tends to put on weight. And over and above this, because this hypoxia is long-standing hypoxia will also contribute to increase of erythropoietin in this patient. So the RBC mass of this person will be increased, because of which you will notice that if you take the blood sample of these patients, the viscosity of blood will be more. In fact, in some of these patients, the cheeks might look rosy. The cheeks would be looking rosy because of, again, the increase in the RBC count of this patient. So these chaps are also having presence of secondary polycythemia. Whenever you read right ventricular hypertrophy in COPD, whenever you read regarding secondary polycythemia in COPD, it means that the disease has been, or if you identify these in a patient, it means that the disease has been present for a very long time. The disease had an insidious onset, I mean, initially because of the splinting nature of the arm activity, like, you know, maybe pushing a shopping cart. He could do that activity. Why he's saying that is, and this is very characteristically given in Harrison, that any activity where the arms are not raised, because if I'm going to raise my arms, then the accessory muscles of respiration can't be used. But if I'm going to splint my arms like this, the accessory muscles of respiration can be used. So there's a special 4-5 line description for this in Harrison, which I'm telling you here. Because of the splinting action of the arms, this guy might be able to do some tasks, which he thinks that, okay, I was physically active, doctor, and you are now telling me that I have a lung disease, and this is so severe. I mean, how did it become so severe if I was not having any symptoms? So I gave you the reason why this has happened insidiously without the patient being aware of how the manifestations have developed. In fact, now I will show you an X-ray of a patient of chronic bronchitis. Now, if I'm given a X-ray like this in the exam, and there's a short history of fever along with respiratory distress, I'll think in terms of COVID-19 pneumonia, especially because the lower lobes of the lungs are having infiltration. But at the same time, if I'm having a long-standing history and this person has had exacerbations to the level that he has required hospitalization also in the previous years, with this kind of a film, I'll think in terms of chronic bronchitis. One of the standard radiological findings that is described for chronic bronchitis would be increase in the bronchovascular markings, though I can just use a casual term here also, that is dirty lungs. So do remember from the description that I've given you that chronic bronchitis, because the patient was having a presence of increase of carbon dioxide, this would be type 2 respiratory failure. And along with this, every time there's gonna be buildup of carbon dioxide in the body, it will contribute to more production of protons, so the person would be having respiratory acidosis. They could be a combination of the two present in a patient also. Let's now look at how the questions on this topic can be framed. One question could be written like this: you have a tall, thin smoker. Now, traditionally, whenever a question begins like this, you should think in terms of that this person could be having emphysema. There's a progressive decline in the exercise tolerance of this gentleman. When he came to me, I noticed that he's sitting on a chair comfortably, but his respiratory rate is faster than normal. I'm also noticing that this person is having use of accessory muscles of respiration. So sternocleidomastoid would be working overtime, flaring of the nostrils could be present, Allen eye could be used. Most of these patients, if they are not good in a sense that they are having worsening of their symptoms, they might be sitting in a tripod position that helps you to splint the arm muscles and use the accessory muscles of respiration relatively better. So this is anyway standard thing that you will notice even in asthma patients, that the person would be sitting in a tripod position. Years of cigarette smoking has contributed damage to his lungs, and the anterior-posterior diameter of the chest of these patients, you see in you and me, the transverse diameter of the chest, shoulder to shoulder, will be more than the anterior-posterior diameter. Anterior-posterior you can measure by keeping your hand in the axilla, but in this particular case, you will notice opposite of you and me, the anterior-posterior diameter of the chest will be more than the transverse diameter, and therefore you will read about a barrel-shaped chest in this guy. And because of the hyperinflation component in emphysema, because the dome of the diaphragm is pushed down, therefore there's a flattening of the diaphragm, and therefore it can push down the liver, so the liver will be palpable. I'm not saying that there is a hepatomegaly. I'll say that again, there's no hepatomegaly. It is just that the dome of the diaphragm is flattened, so it will push down the liver. So liver may be palpable, may not be palpable in these patients, but we do not usually encounter cyanosis in patients of emphysema. So this would be the kind of a history that he would be giving you for a person who's having primarily emphysema. As the disease progresses, you might even notice that he might write cachexia, and the first impression in our mind whenever we read the word cachexia is he talking about a cancer? But what we have found is that weight loss can definitely be a indicator of the deterioration of these patients. Bitemporal muscle wasting would be present. The last time I have used the word bitemporal muscle wasting is for a person with cirrhosis, like a chap with alcoholic cirrhosis. I have described gynecomastia, testicular trophy, bitemporal muscle wasting. Now today I've again talked about this. Or just he might just say diffuse loss of subcutaneous fat. I mean, it's on the examiner, whichever of the three terms he wants to use, but these three indicate poor prognosis in these patients. Overall, I would say, I mean, clinically speaking, what is a poor prognostic indicator? You will notice that there is a overall loss of subcutaneous fat in the body of these patients. Now let's look at the workup that would be done. And since the respiratory distress can increase, especially if there's a viral pneumonia developing in these patients, you might even have what is called as Hoover sign. Hoover sign simply means that the lower part of the chest will be sucked inside. You see, in you and me, whenever we breathe in, the whole chest expands. But in this chap, the diaphragm will contract. It's already a flattened diaphragm. So the ability of the diaphragm to ventilate is anyway hampered. And this diaphragm, when it will contract with more force to take care of the hypoxia component, then there would be a paradoxical inward movement. You would have seen this kind of a description even in pediatrics. They use the word subcostal retraction. So I'm using that term subcostal retraction, but I am just assigning a name to it. Hoover sign simply means a paradoxical inward movement of the rib cage, or especially of the lower part of the chest. This is primarily a mechanism which is telling you the fact that there is overwork on the respiratory muscles. There is overwork being performed by the diaphragm per se, and it's not going to persist. I mean, the diaphragm will not be able to do this over for a substantially long duration. So you might have to admit these patients once they start having sudden deterioration with a Hoover sign, and we will have to put these patients on non-invasive ventilation to reduce the work of breathing. Towards the end of the discussion, I'll describe non-invasive ventilation, also indications and contraindications, and that's one of the most important parts of this particular discussion. But you have to pick up, whenever he talks about sudden respiratory distress and there's gonna be like x-ray findings on pneumothorax, then you will be able to anyway pick up that there was a rupture of a bulla. But he starts talking about a chronic bronchitis chap having very purulent bronchoria, presence of a Hoover sign. This means that there's a very severe deterioration to the level that the person might be having a requirement of a non-invasive ventilation also. And I mean, it's not that Hoover sign would be seen only in emphysema patients or only in a chronic bronchitis patient. It really does not matter, because I said the two diseases would be having a spectrum presentation. So whatever I am saying, I am repeating the statement. I said this even in the starting, that in the exam they will give you presentation which will be overlap of the two, because that's the reality situation. But since I am introducing this topic before you, I'm trying to describe it in, I would say, shades of black and white. So let's now look at whatever description that I'm giving for green is primarily for emphysema, and let's now look at what are the workup findings which would be noticed by you in a multiple choice question. The first test that I'll be doing for this patient is anyway the investigational choice for this condition, spirometric evaluation, and he's going to describe the following parameters: timed vital capacity, or FEV1, FVC ratio will always be less than 0.7. Residual volume is increased thanks to the air trapping, total lung capacity is also increased, and even FRC. FRC is functional residual capacity. It is a combination of two things. It is combination of expiratory reserve volume and the residual volume, and because residual volume is showing an increment, so I'm just putting a up arrow here saying that functional residual capacity will also be increased. The HRCT will be revealing multiple bullas, and in fact we do plan a surgery for these patients also if the bullas are big. That would be called as lung volume reduction surgery, or I can just casually use the word bullectomy. If I perform a X-ray chest, the standard findings I've already explained to you: flattening of the diaphragm, and if he uses the word hyperinflation in a chest X-ray, he's making it easier for you. DLCO stands for diffusion capacity of the lung for carbon monoxide. In this patient, DLCO will always be less. Let's look at what are the reasons. Reason number one for DLCO being less in this patient will be the delivery of oxygen inside the alveoli is lesser because the air was getting wasted in the blebs. The second reason will be, I said, alveolar scarring. So because of the combination of the two, the delivery is also lesser, and even the alveolar scarring component is present, the DLCO value would be given to be lesser. We routinely will not perform ABG in this person. This is an academic discussion, so I'm just mentioning at the moment that the PO2 of these patients will always be less, and because of hyperventilation, the carbon dioxide values will either be on the lower side of normal or will always be less than normal, which is the finding for respiratory alkalosis or type 1 respiratory failure. And now let's look at what we will do for the management of these patients. At the moment, I'm talking about the treatment perspective, not from the gold classification aspect, which will come up subsequently. I'm just talking about generalized steps which you need to take to alleviate the symptoms of these patients, and the first one would be a nicotine de-addiction. For this nicotine de-addiction, we can be using nicotine replacement therapy. So this chap can be using a nicotine buccal spray. We also have a chewing gum available, but I wrote buccal spray first because it will act instantaneously, so that craving which is present in a cigarette smoker, that okay, I have to go and smoke, that would be taken care of because the nicotine will be replenished. Apart from nicotine replacement, there are a couple of other drugs which you have read even in pharmacology, and the brand name for this is Chantix. The molecule that I'm talking about is varenicline. Now, how this molecule acts is that it acts on the very receptor which gives a cigarette smoker a pleasure. So the receptor here would be called as alpha 4 beta 2, and this drug that I'm describing to you, this is a partial agonist of this nicotinic receptor. Listen to my words very carefully. I said varenicline, brand name Champix, known by various names. This drug is not an antagonist. It is not an antagonist. It is an agonist of the alpha 4 beta 2 nicotinic receptor. And you very well know from your pharmacological knowledge that you don't need only an antagonist, but even an agonist could be blocking the action. The pleasurable effects of smoking would be curtailed. If you just Google the word varenicline or Chantix or Champix, it's available as 0.51 milligram tablets. Course has to be taken for 3 months, and along with obviously counseling of the patient, you would be having about a 50% reduction in the chances of the fact that, I mean, this person will give up smoking. I mean, we cannot be 100% sure because it is dependent on the willpower. But what I'm saying is, if you will just do a Google search about this drug, a lot of these fake websites might be present, which might be saying that this drug promotes suicidal tendencies. Now, per se, you know, I mean, yeah, obviously every drug can be having side effects, but this has not been validated per se. So lots of time what I want to say is that these tobacco companies, they might be actually, you know, because their profits will obviously go down. The more people smoke, the more the tobacco company will make profits. So I'm not against profits, but what I'm saying is that it should not be at the cost of health of somebody. Right. So the message is that lots of time these websites might be claiming facts which may not be medically documented to be 100% true. So varenicline, I mean, the search result, you know, usually shows this, and I get a lot of queries from my students also that, sir, does this drug cause suicidal tendency? Well, the Federal Drug Authority would not have given permission for a drug, no, if it's gonna cause people to develop a suicidal tendency to such a large extent. So I'm not discrediting, because every drug you use can obviously cause some kind of a imbalance and can cause problems, but the point is, per se, varenicline is used in combination with nicotine de-addiction, and if FDA has given approval, they must have thought something before giving an approval here. Another drug which we are using is also an anti-anxiety drug, that is bupropion. So you might be having pharmaceutical representatives coming to you and telling you that our company is manufacturing varenicline bupropion combination also. But if all the drugs are given and they ask you to select one from the perspective of prevention of deterioration of this emphysema predominant COPD patient, mark my words there. If the question simply says which is the mortality reducing step in COPD patient, I have already told you it is low flow oxygen. But if he says for the prevention perspective, whatever damage has occurred has already occurred, I don't want this guy to deteriorate even further, then from the prevention perspective, I not only need to ensure that he is fully vaccinated, but I also need to ensure that he gives up on cigarette smoking, or at least reduces the number of cigarettes that are smoked every day. Along with this, even surgery would be done in these patients if documented. The bullas can rupture, so video assisted thoracoscopic surgery can be done. Here the bulla will be definitely removed, which I can call as a lung volume reduction surgery, and this would be a thoracoscopic surgery. I mean, you introduce a pinhole camera into the chest. I mean, there's no big scar that would be present, because whenever you tell somebody we're gonna operate and cut open your chest, the person will obviously freak out. So here we are using a robotic arm that goes inside and performs the bullectomy procedure. And anyway, these patients are also candidates for lung transplantation. Please remember the number one cause. In fact, I can just put it on record that the number one cause of lung transplantation is idiopathic pulmonary fibrosis. If idiopathic pulmonary fibrosis is not given in the options, then the answer would be given as COPD. Do remember this fact. Earlier in older books, I mean, the data was slightly different. The current edition of Harrison mentions 30% value in front of IPF and 27%, only a 3% difference. But then I'm quoting these values because you can argue, sir, we have read a different data in a different book. So yes, that difference of opinion we have to respect as a doctor. But in Harrison, the standard book which is used in the exam, they have put a value of 30% with IPF and 27% for COPD. So that's why I said the number one cause of lung transplantation is idiopathic pulmonary fibrosis. Now the next description that I'll be giving to you will be for a patient of chronic bronchitis. So this time he might be mentioning regarding a fat or a obese smoker, and let's look at why he has come to me. The main complaints of this patient will be a continuous racking cough, productive in nature. There will also be mention of bronchoria. In fact, he might talk about purulent bronchoria. So there will also be halitosis. And because I'm talking about pus here, because I'm talking about infection in this case, so this can definitely damage the airways, and therefore you could also be reading regarding hemoptysis in these patients. It's not a presentation which is very common considering the fact that we have very good treatment strategies available for management of these patients at the moment, but considering the historical perspective, I will say that halitosis is well documented in neglected cases. We do not have presence of clubbing in any patient of chronic bronchitis. This is itself an MCQ, so I'm just highlighting it. Clubbing is not seen in COPD. It's not seen in patients of chronic bronchitis or emphysema. If you find a smoker is having clubbing, you must scan the person with a low dose CT, and if low dose CT is not available, a standard CT for a lung cancer. I repeat the fact once again, if you read a question, even if he is having chronic bronchitis, he is a known case of chronic bronchitis, he started developing clubbing, that means that there's a possibility of this guy having a developmental lung cancer. Then would be a examination finding that would come up of turbulence, that would be rhonchi. They would predominantly be expiratory. But as the disease, I've just highlighted that predominantly expiratory, but as the disease will progress, if there's a deterioration, during deterioration, you might be having both inspiratory as well as expiratory rhonchi in these patients. For the workup, I'll be doing the same thing even in this person. I'll be performing a spirometry initially that will reveal FEV1, FVC ratio of less than 0.7. Chest X-ray will be showing dirty lungs. The technical term that I used, however, was increase in the bronchovascular markings. This is mainly because there was a low-grade infection and he had to take multiple antibiotic courses for the same. To confirm the diagnosis, I'll be able to demonstrate the airway plugging by the lung secretions by performing a HRCT. The diffusion capacity of the lung for carbon monoxide is found to be normal in patients of chronic bronchitis. This is a slight fundamental difference I want you to remember. In emphysema, DLCO is lesser because you have alveolar scarring. But in chronic bronchitis, we usually find DLCO to be normal. Though, in the exam, if he just says COPD, if he just says the word COPD, then your answer will be that okay, DLC of the person can be reduced because emphysema could be a predominant presentation of the disease. But otherwise, fundamentally speaking, if you just look at the disease from the pathological domain, then I can say alveolar scarring explains why DLCO is substantially reduced in emphysema, and chronic bronchitis alone present, then DLCO can be normal also. We routinely do not do ABG in patients. We do ABG only if there is an exacerbation and the person is admitted and I think that he will require ventilatory support. That's when I'm going to do a ABG. But still, because this is an academic class, I can say that PO2 of this patient will be less. I have pulse oximeter. No, I will check pulse. I will check SpO2 by pulse oximeter. I don't need to do a ABG. And the values of carbon dioxide in these patients can be on the higher side of normal or grossly elevated. So that would be type 2 respiratory failure. And every time the PCO2 values are given in a MCQ of COPD exacerbation, they would be usually like 55, 60. Those are the ranges that would be given to you. Now, for the management of this particular case, I will have to use antibiotics. When I was describing emphysema, I did not speak anything with respect to antibiotics because there were no lung secretions per se. There was no infection component that was present, but repeated courses of antibiotics with mucolytics. Why mucolytics? Because they will enhance the penetration of antibiotics at the site where the infection is present. Along with this, I'll be using LAMA. The molecules that are commonly used are like tiotropium. That would be slightly because of longer duration of action. Then we can be using salmeterol, we can be using budesonide, that is inhaled corticosteroids for management of these patients. And anyway, the mainstay of treatment is what I'm highlighting here. That would be low flow oxygen. Along with this, I want to repeat the fact that this is the single most important mortality reducing, I would say, intervention done from the physician's perspective. The amount of oxygen that would be given would be 1 liter per minute for max number of hours he can take. I'll not force the patient to take oxygen 24 hours a day. It's not practically possible to, put up a nasal cannula. It will cause a bit of irritation, discomfort for the patient. So I will say try to use it for as much as possible. And the patient is asking me, sir, how will it help? So it's not that it's going to cause a dramatic changes in the lung parenchyma of this person. The only thing that low flow oxygen will do is it will increase the amount of dissolved oxygen in the blood. So the ability of this person to go to the bathroom by himself, or maybe take a bath by himself, or maybe change his clothes, because the severity of distress in chronic bronchitis patients, I anyway told you hypoxia is more severe in chronic bronchitis because of the hypoventilation component. So even small tasks like cleaning yourself after going to the washroom or changing a pair of clothes after taking a bath may make these patients very breathless. So all I'm doing is trying to increase the quality of life of these patients by prescribing low flow oxygen. And from the exam perspective, he can ask you here that, I mean, SpO2 less than how much, because you're using a pulse oximeter routinely. You're not going to do a ABG on a routine basis, no? So he will ask you that if you are given, you have prescribed a pulse oximeter for this person, then at what level of SpO2 would you be starting this intervention? Then SpO2 of less than 88%, remember this value. If SpO2 is less than 88% at rest, or another cutoff to be remembered, you can very well see why I'm using a different color, because this is important from the exam perspective. He says SpO2 less than 89% if pulmonary artery hypertension has already developed in the patient. If there is a problem with the right ventricle, why right ventricle will be affected is because pulmonary artery hypertension will occur. Because if there is hypoxia causes constriction of pulmonary vessels. Hypoxia causes dilatation of all vessels in the body. But pulmonary artery is an artery which is different from other arteries because it does not contain oxygen, it contains carbon dioxide. So pulmonary artery behaves opposite of the way other blood vessels in the body will behave. It will constrict in response to hypoxia. So the cutoffs to be remembered are 88 and 89. And I did have queries saying, sir, should we answer 88 or 89? So it depends on whatever is given in the question. Most of the time he will describe you that a chap of chronic bronchitis, a blue bloater, is having respiratory distress even at rest, and his SpO2 by the family member is reported to be 85% after multiple re-evaluations. Initially they thought maybe the pulse oximeter might be not working properly, but then the values are lesser, so low flow oxygen has definitely to be introduced for management of these patients. I mean, this is the threshold at which you would like to intervene. So I'll just go back in my slides to highlight that this data in green that I've highlighted before you, this is primarily for a person with emphysema, whereas the data that I have put at the moment in color blue, this is predominantly for a person of chronic bronchitis. And I have already put up the disclaimer that the patient can be having a combination of these findings as well. So next we are going to study regarding GOLD, that is Global Initiative. The full form of GOLD would be a global initiative for patients who are having chronic obstructive pulmonary disease. So we're going to talk about a GOLD classification, on the basis of which the treatment of these patients will definitely be decided. The categorization which would be done here would be a mild, moderate, severe and very severe. Now why it is asked is primarily because there can be confusion with respect to severe and very severe, because traditionally any classification you read, you always read mild, moderate, severe, but here you have to remember there would be 4 categories which would be present, and in all 4 of them the initial data will always be same. FEV1 FVC ratio will be less than 0.7 in all of these categorizations that I mentioned before you. The differential will be in the value of FEV1. If you notice that in any question, the value of FEV1 is given to be more than 80%, whereas in another person or in another MCQ you notice FEV1 is given to be, let me say, 55, 60, 70%, between 50 to 80%, then when you are reading the value in the question of FEV1, even before the bronchodilator, after bronchodilator, these mathematical values, you have to understand that from the exam perspective is telling you that is it a mild case of COPD or is it a moderate case of COPD. As far as the severe case is concerned, the FEV1 will be between 30 to 50%, and for very severe variety, remember this, at this point the person will be so breathless that he will not be even able to talk to you. Forget about going to the bathroom or doing anything unassisted. The guy will either talk to you in monosyllables, yes, no, or shake his head, or just try to do like this and say, sir, I'm not getting breath, please do something. So very severe is a term which has to be remembered for FEV1 values which are less than 30% for these patients. If they are in the range of 30 to 50%, it would be severe. And most of the time what I have found is that people tend to answer these erroneously. It will look very simple at the moment, but believe me, when you pile up all the data together with so many classifications that you have to remember in surgery as well as in medicine, then I find that this simple classification can also go wrong. For the management of these patients, one of the most important drugs that has to be introduced is LAMA. Tiotropium can be used. Along with this, even LABA can be used, salmeterol. In fact, initially, I might be even prescribing to these patients SABA also. In some cases, mild cases, I can prescribe SABA also on and off basis. But studies have shown that ultimately, because there's a progressive deterioration, so then you will have to add anyway LABA and roflumilast, that is a phosphodiesterase 4 inhibitor has also been used in these patients with good results. So triple therapy involves the first three, but even roflumilast can be mentioned. In spite of using these drugs, there can still be an acute exacerbation that would be developing in these patients. If he talks about this word acute exacerbation of COPD, then two things will always be asked to you. Point number one will be that what will you do for management of this chap? Then you will have to put this person on non-invasive ventilation. I'll talk about indications and contraindications of NIV on the subsequent slide. But one, they will ask you what will you do initially for management of this patient? Then obviously the standard drugs will continue. But the main way to reduce the work of breathing in this person, the main way to get this guy out of this state where he is not even able to answer you simple queries like what is your name, he's just shaking his head and saying, sir, I cannot even I mean, he's trying to signal with his hand that, sir, when you are asking me questions, I am not feeling comfortable, I feel as if I will die. I mean, most patients, you know, you will notice they'll just try to act like this, sir, I'm not getting sufficient breath. So you will have to put the patient on non-invasive ventilation. And the next question, which can be an option of the same MCQ or can be a different MCQ, will be what will be the target SpO2? You say in COVID-19 we try to get a target of 92% or even higher, but in patients of COPD, because there is already a lung damage, we will not try to target values going up to 92 to 95% or even higher. Our target here will be 88 to 92%. So two important aspects which are very important from the perspective of management of a person of acute exacerbation of COPD is usage of non-invasive ventilation and the target which is to be achieved. And over and above this, I've already explained to you that non-pharmacological interventions are anyway to be used in these patients. Non-pharmacological interventions would mean like smoking cessation, vaccine, and in fact the vaccine component I'll mention in the COPD update component also, because I'm just saying it verbally. There's a subsequent video after this COPD update. In that I mentioned the 2021 guidelines, the gold classification 2021 update, and they have made it mandatory to even use acellular pertussis vaccine in these patients. Remember I said you need to give COVID vaccine to these patients, you need to give pneumococcal vaccine, but apart from COVID-19 pneumococcal, even acellular pertussis vaccine. I'll write it down in the subsequent video which is just after this, but just giving you a heads on here by telling you that acellular pertussis vaccine is gonna reduce the incidence of exacerbations. It's a non-pharmacological intervention to prevent deterioration of these patients. Now for delivery of non-invasive ventilation, all of you in your COVID wards would have seen this tight fitting face mask. Well, it's very difficult to be put on those patients who are claustrophobic. I mean, if a person is not compliant here, then it will be very difficult to maintain oxygen saturation and you might have to go for a mechanical ventilation of the patient. But you can very well see that if a person is able to tolerate it, then you will be able to reduce the chances of barotrauma, you will be able to reduce the complications of endotracheal intubation, you will be able to reduce the incidence of ventilator associated pneumonia. So either a tight fitting face mask, or you would have also seen this helmet interface available. There are two ways by which we can be delivering non-invasive ventilation to our patients of COPD exacerbation. And apart from COPD exacerbation, he can definitely ask you about other indications also. At the moment, I'm primarily the first 3 points. I'll talk about COPD, and then I will also tell you about other uses of non-invasive ventilation. Out of all the uses that I will tell you subsequently, If he says NIV has been shown to reduce mortality in which category, your primary answer would be acute exacerbation of COPD. Listen to this carefully. You will notice me later on saying that NIV is used in acute pulmonary edema. We can also be using it in patients who are having neurological diseases, neuromuscular paralysis like myasthenic crisis. But out of all the aspects that I'm going to teach you subsequently, I'm giving you a heads up by telling you this fact that NIV has been documented substantially to reduce mortality in acute exacerbation of COPD. The indications would be whenever the person is having a severe manifestation. Severity I've already explained to you will be FEV1 FVC ratio less than 0.7 and FEV1 values between 30 to 50%, or it is lesser. This is definitely the time when you might require this intervention to be done. When you will perform ABG, there will be evidence of acidosis. This would be a respiratory acidosis with carbon dioxide values that would be spiking. So these conditions that I'm writing before you, if they are satisfied, you are having a severe COPD. Along with that, there's a acidosis, there's a buildup of carbon dioxide, and the SpO2 of the patient is less than 90. Then all of these indicate that the person should be given a non-invasive ventilation. Now, the other uses of non-invasive ventilation that you need to remember would be one, person of bilateral pneumonia. The best example of bilateral pneumonia I can give you is a person of COVID-19 pneumonia. You would have seen so many cases of COVID-19. Bilateral lower lobe infiltration is what is commonly seen, and these patients were put on NIV with very good results. The next chap is having myocardial infarction. He has developed a acute decompensated congestive heart failure and has ended with acute pulmonary edema. You see, for management of this patient, I'll be using LMNOP, Lasix, morphine, nitrates. But how will I give oxygen? Via non-invasive ventilation for these patients. The next case is having a neuromuscular disease. This is a known case of myasthenia gravis. This lady, she developed some infection, or maybe during pregnancy has deteriorated to develop myasthenic crisis. So to help her tide over this crisis where her diaphragm is not working, non-invasive ventilation can be used to ensure that the oxygen saturation is maintained till we give immunoglobulins to this patient. Then even if a person is in your intensive care unit and is on a ventilator for a long duration, then non-invasive ventilation has been successfully demonstrated to help a person wean from a ventilator. So there are 5 indications. I'll repeat again: acute exacerbation of COPD, which is the first answer in the MCQ, COVID-19 pneumonia / bilateral pneumonia, pulmonary edema, neuromuscular diseases, it could be GVS also, and then weaning from a ventilator. And next I'll describe to you what are the contraindications for non-invasive ventilation. And the first and the foremost would be that the person's GCS should be at least that he should be able to take care of his airway. Suppose you are having a comatose patient who's totally unresponsive with a very low GCS score. Because these patients are prone to aspiration, using a helmet interface like I showed you or a tight fitting mask might be counterproductive in the perspective that this person cannot tell you that he's not feeling well, and there could be a high incidence of aspiration pneumonia. So he might write it as unresponsive patient, he might write it as inability to protect airways, or if there is high amount of secretions present in the airways of this patient. If he says bulbar palsy present in a patient, yes, bulbar palsy has a high incidence of recurrent episodes of aspiration. Then if a person has had facial trauma, in fact, this tight fitting face mask also, now for when you use it for long duration in your COVID-19 patients, it can contribute to facial trauma. So sometimes, I mean, you might have to change it to a helmet device. So facial trauma, or if a person has undergone a facial surgery, then this is again a contraindication for doing this. If there is demonstration of apneic episodes, if this person is having apneic episodes, that means the brainstem is damaged pretty bad, like in a head injury case, and you are noticing Cheyne-Stokes breathing and there's an apneic episode occurring also, it tells you the fact that you have to go for a mechanical ventilation in this patient. Similarly, if there is hemodynamic instability. In short, if I simplify the data, I just want you to imagine a person who's having moderate to severe COVID-19, where the person can tell you, sir, I'm not feeling well, I'm having breathlessness. So if you're having a patient whose sensorium is clear and the person can at least communicate at least basic aspects to you, like how am I feeling, then I think it's safe to use a non-invasive ventilation. But if you are having a progressive decline in GCS with the aspects that I've said, it's a big no. And from the disease perspective, I can say if somebody has had MI, unstable angina contributing to heart failure, or if somebody has had a severe GI bleeding, now I don't want him to bleed with a mask on. I mean, the blood will not be able to exit and it might actually go into the airways of the patient. So if you read the contraindications for non-invasive ventilation, I think just deploying simple logic, facial trauma, facial surgery, a person who's prone to have, I would say, aspiration because of bulbar palsy, those are the kind of words which can be picked up by English also in a question. So contraindications to non-invasive ventilation is, I don't think, will cause any problems, and it's rather indications that I've highlighted which will be more important, especially from the perspective of COPD, which is the primary objective. And after this, I want you to watch on the loop itself the COPD update, where I've talked about categorization of patients depending on the symptom severity. I'll be teaching you what are the assessment tools that we use to grade the severity of the disease. I'll be talking about MMRC, severity of dyspnea. I'll be talking about COPD assessment tool, CAT, COPD assessment tool, and then I'll tell you how would you prescribe drugs. So I've talked about the drugs already, but how would you prescribe the drugs would be dependent on this, or will be described in the subsequent video. Thank you so much for hearing me out, and do listen to the subsequent part.